Well, hello everyone and good evening. My name's Sanjay Popat. I'm a consultant medical oncologist at the Marsden and Professor of Thoracic Oncology at the Institute of Cancer Research. I'm delighted to host this evening's BTOG webinar. This is the third in the series of webinars that we've been doing in recent times. This evening, we're going to be discussing the abstracts that were presented only a few days ago at the World Lung Cancer Virtual Presidential Session. I'm delighted to be joined by a number of excellent guests, and if we move on to our program, thank you. If we move on to the program, you'll see that we'll be talking about three excellent data sets. We have the Orient 11 data set, the EXALT 3 data set, and the CheckMate 743 data set, potentially practice-changing trials. I'm joined by three colleagues this evening who'll be discussing each of these trials in turn. The first of my colleagues is Dr. Alastair Greystoke. He's consultant medical oncologist at the Freeman Hospital in Newcastle and senior lecturer at the University of Newcastle. So without further ado, Alastair, it'd be great to have your take on the data, the Orient 11 study. Thank you.
So I'd like to thank the members of BTOG for inviting me to talk about this interesting abstract that was the first presentation on Saturday afternoon. And this was the Orient 11 study, which is a randomized controlled study adding in Sintilimab, which is a PD-1, to standard chemotherapy of platinum and Pemetrexed in the frontline therapy for patients with non-squamous lung cancer. It was a study that was performed at 47 hospitals in China. The study schema is pretty much as you'd expect from a study of this type. So patients had to be untreated, stage 3B or 4, fit with performance status 0 to 1, no EGFR or ALK abnormality, and able to provide a PD-L1 sample. They were randomized in a 2-to-1 fashion to standard chemotherapy with platinum or Pemetrexed for 4 cycles and maintenance treatment with Pemetrexed, and either Sintilimab for up to 2 years or placebo. Importantly, patients who are randomized to placebo in the standard of care arm, if they had central confirmation of progression, could cross over onto monotherapy Sintilimab afterwards within the study. The stratification factors were as you would expect, but in particular, I'll point to you that the PD-L1 was stratified at PD-L1 of less than 1% or more than 1%, not at the 50% mark. The primary endpoint, which I will talk about later, was progression-free survival with a range of other secondary endpoints, including overall survival. They treated just under 400 patients, and interestingly, it seemed that they screened over 800 patients to get those patients. I haven't been able to find out why the patients dropped out. I imagine a number of it was given the patient population, either EGFR or ALK status. Importantly, I will point out that within the study, 35 patients were able to cross over to monotherapy Sintilimab. In the paper, they describe that another 6 patients have crossed over outside the study, leading to about 2/3 of the patients who've progressed on standard of care chemotherapy now receiving monotherapy immunotherapy. You will see that there are a number of patients ongoing with treatment in both arms. The baseline characteristics are very much as you might expect, although there was a high preponderance of males, with 3/4 of patients being male in both arms. You'll see also that 3/4 of patients received carboplatin rather than cisplatin. What is different about this study is the high rate of never smokers, about 35%, which I'll discuss later on. This was a positive study that met its primary endpoint. So there was an increase in progression-free survival from 5 months to just under 9 months, with a hazard ratio of 0.482, which is heavily significant. And you can see the curves start to split even at the first scan and seem to be staying apart for as long as we have follow-up. This improvement in progression-free survival was seen across all key subtypes, with the only subtype that's doing particularly well, as you'd expect, the patients who had the high PD-L1 expression, where the hazard ratio was down at 0.31. But otherwise, all the subgroups seemed relatively equivalent. Looking at the PFS curves across the different PD-L1 expression, you will see that for the high PD-L1 of more than 50%. The curves are coming apart nicely and staying apart with a median survival that's not yet been reached in this arm. But results, as we've seen in other studies, that are not quite so promising, but with significant improvements, including in the 1 to 49% and the less than 1% data. But in both these arms, the improvement in progression-free survival was on the order of about 2 months. We do have some overall survival data, but it is very immature. The median follow-up in the study is only about 8 months. You can see that the curves do look to be separating, and we hope they will continue to stay apart. There was a positive hazard ratio at 0.609, which was statistically significant, but this is very immature data, and I think it's probably too early to comment too much on this at present. As we've seen with other chemotherapy and immunotherapy studies, the response rate was higher. It was only 30% in the standard of care arm, and it went up to 50%, just over 50% in the combination arm, including some complete responses. Also, interestingly, to my mind, responses seem to be quicker in the combination arm, with a median time to response of only 1.5 months, while it tended to be at second scan that they met formal response in the standard of care arm. So higher and quicker response rate with some complete responses seen. When you add in another drug, obviously it's important to think about potential toxicity. So this is the chemotherapy toxicities that were demonstrated in more than 20% of the patients. And you will see that there was no real major differences across all these chemotherapy toxicities that we saw. As you also may have expected, we did see an increased incidence of immune-related adverse events. Here described those that occurred in more than 2% of any patients. Most of these are ones that would not particularly worry us, such as hypothyroidism or a low-grade increased amylase. I was slightly worried about the high rates of immune-mediated pneumonitis, but as you can see, again, most of the increase was in grade 1 to 2 occurrence. And there was also some increase in rash that can be troublesome in patients that are on this chemotherapy and immunotherapy combination. So we've seen a number of trials in this setting looking at different immunotherapies added onto first-line chemotherapy. And the question that this led to me to ask is, when do we need another drug in class? Obviously, if we can see improved efficacy or improved tolerability, that is of importance to our patients. Sometimes it can be helpful when there's a borderline effect and we need a number of studies to enable a meta-analysis to give us confidence that this is a genuine effect and is not a statistical fluke. Sometimes we only have data in a certain population that may not be applicable to the patients we treat in the real world, and that it can be useful to have another trial that can give us more data in the setting. Different agents sometimes have different mechanisms of resistance, and that can also be helpful in determining which one we should use in our patients when thinking about subsequent treatment options. And these drugs are expensive, and we would hope that the more drugs we have available, that it may lead to competition and hopefully improved costs, and therefore improved availability to our patients within a national healthcare system. So how does that work out for this study? Well, this is a slide from Dr. Nagasaka, who discussed this presentation on Saturday, and she compared it to Keynote 189, the carboplatin and Pemetrexed study, which was relatively equivalent, but has more follow-up. What you will see is very similar improvements in response rate and progression-free survival that are very similar again, both in the standard of care arm and in the experimental arm, with improvements in both from approximately 5 to approximately 9 months and very similar hazard ratios. As I'd commented earlier, we haven't seen the survival data, but again, the toxicity rates looked very similar. So there doesn't seem to be any major difference in efficacy or toxicity from this regimen, as far as we can tell at present, to the Keynote 189. What is important is this slide looking at a different patient group. Obviously, this was a study carried out in China and had a 100% East Asian population enrolled. This compares to some of the other studies which had enrollment of patients who have East Asian ethnicity of between 1 and 14%. So it gives us valuable data in this population. Equally important, most of the studies that we've previously seen have had relatively low rates of non-smokers, somewhere around 10 to 15%. And we haven't been clear of the benefits in this population. This study, almost a third of patients were never smokers. So my thoughts about this study is, whilst it doesn't show us any advances in efficacy or tolerability, and we're already confident that adding in immunotherapy to chemotherapy could improve certainly progression-free survival, we do now have data in another population, the East Asian population, the never smoker population, that can be helpful in our discussions with patients. Whether this will lead to increased competition and will lead to increased costs, I think is a discussion maybe afterwards or over a beer in the bar. I would criticize, I think the trial design is appropriate apart from the use of PFS as a primary endpoint. Patients who are fit to receiving chemotherapy, most of them should progress to immunotherapy in the second-line setting. And really seeing whether we get an increased progression-free survival may not be the most appropriate endpoint here. And I've shown this in this bar here, that patient who receives chemotherapy and immunotherapy, you might get similar outcomes from receiving chemotherapy as receiving chemotherapy and immunotherapy together, but at the risk of increased side effects. And I think studies of this type, we should be looking at overall survival endpoints, maybe long-term survival rates, although these do take longer to accumulate. And what about thinking about patient-reported or payer outcomes, such as quality of life, healthcare usage, and health economics? So we have another chemo-immunotherapy combination, which is unlikely to be licensed in the UK, certainly unlikely to be funded in the UK, but we do have valuable data in the East Asian population. What do we really actually need? Well, we need to know how to treat these patients when they progress on chemotherapy and immunotherapy. We need a better understanding of the biology in this setting and newer treatments. One thing that's very difficult in my practice is knowing when to change therapy in patients on chemotherapy and immunotherapy. And I will point out that in this blinded study, 35% of patients were treated beyond progressive disease on the placebo arm, which we would never do if we were just giving chemotherapy alone, if we thought we were just giving chemotherapy alone. We have difficulty determining the etiology of side effects when patients are on multiple drugs. 37% of patients on the placebo arm were said by the investigators to have had an immune-related adverse event. And importantly, going forward, we need to know which patients we can miss out chemotherapy for or give less chemotherapy for, how it interacts with tumor genomics. Although EGFR and ALK were excluded from this study, other genes were not tested, including things like BRAF, RET, or some of the genes associated with immunotherapy resistance, such as STK11. And what I really want to know is how I can deliver treatments like this or get the best outcomes for my patient population, which are older, have multiple comorbidities and frailer than the patients that have been enrolled in the clinical trials we've seen to date. And with that, I'd like to thank you for your attention and take questions.
Alastair, thank you very much for that great overview, and you're welcome, attendees, to type in your questions, which I will then attempt to pass on to Alastair to get his input. So whilst you're thinking of something interesting to ask, Alastair, can you tell me what is Sintilimab? I've never heard of this drug before Saturday. Just educate me.
So it's an anti-PD-1 therapy like Nivolumab and Pembrolizumab. It is licensed for treatment of Hodgkin's lymphoma in China. It does have slightly different binding than Nivolumab and Pembrolizumab, both of which also have slightly different binding from each other. And preclinically, it does have different efficacy in animal models. But as I've said, the clinical data looks very similar to Pembrolizumab, maybe slightly different to Nivolumab, but that was a different trial design.
So if I can ask you about the trial design, obviously you've compared it very much to Keynote 189, which is generally what most of us are using our chemo-IO combinations on the back of. Were there any major differences in the trial design between Keynote 189 and Orient 11?
I think the crossover was better in this study. I think it was done in a more rigorous manner. As I remember, Keynote 189 had dual primary endpoints of progression-free and overall survival. As I said, I'm not even sure progression-free survival should be a primary endpoint, but I certainly would have gone for dual primary endpoints. But otherwise, they're very similar in allowing platinum Pemetrexed, although in both studies we saw carboplatin as a dominant thing, using maintenance Pemetrexed throughout and using IO in a randomized double-blind fashion. But the crossover was different and was better in this study. That has been criticized in the 189 study.
So I want to focus in on the never smokers a little bit. There were a lot of never smokers because I guess the biology of lung cancer is different in East Asia. those patients seem to have a better benefit. We sort of signal for this in 189 as well, but not in 024 and 042. So chemoimmuno seems to have a benefit. Who are these never smokers? Because EGFR and ALKs were excluded. So who are they? And do we really believe that this is a preferential treatment for them? And I guess the subsequent question is then, if we're using chemo pembro for the UK patients, should we be preferentially using that for the never smokers? Too many questions for you to ask, but you know where I'm coming from.
Yeah, so first off, who are these patients? Well, we don't know. I'm hoping that we'll see some more genetic analysis from these patients because, you know, in my never smokers who don't have EGFR ALK, you see a huge range of abnormalities, some treatable with other tyrosine kinase inhibitors such as BRAF and RET, some not presently treatable. So, you know, I see never smokers with KRAS mutations, sometimes with STK11 mutations. Sometimes you never even determine the underlying mutation in that never smoker population. So I would love to see a biological study of these. Should we be giving the immunotherapy in combination with chemotherapy for the never smokers? So my answer to that is yes, if they're well enough. And I think the rationale is that in these fitter patients, these patients are metastatic disease, you're not going to cure them, but equally, you going to allow them to progress and die on your watch without ever having received immunotherapy? And we know that these patients may do less well with single agent immunotherapy. So let's give it with chemotherapy, give them the best shot. It does mean that when they progress, you have less options. And I think that's why I was trying to highlight we need better options for these patients, either genomically driven or with some of the new antibody drug conjugates coming through. But I would say that for a fit non-smoker in the absence of a treatable molecular abnormality, I would be treating them with chemotherapy and immunotherapy. I don't think in this study they appropriately excluded all the treatable molecular abnormalities like ROS1, BRAF, etc., that we now have access to treatments in the UK.
Can I come back to you on that? I mean, some would argue that the risk of giving chemoimmuno to the never smokers up front is if you've missed an EGFR mutation, false negatives, then you end up giving osimertinib after pembro priming, and we know that that's a pretty toxic combo. What are your thoughts on that?
Yeah, so you need to be clear, and so number one thing is we need to get the results back for these patients' molecular profiles quickly. You know, the median 18 days turnaround shown by the National Lung Cancer Audit is not good enough. To my mind, in future, it would be nice to have a joint tissue blood approach because that gives you confidence. Most of these patients do have circulating free DNA, and if you miss it with one, you pick it up with another. But you know, you can't test and retest hoping they're going to have an EGFR mutation. You do just need to get on. So I would make sure you get your test back properly, reflex testing. If you can do tissue and liquids out front, that's great. Some of us have access to it, some of it don't. But if you don't find anything treatable, get on with treating them, you know, and then because you need to give them appropriate treatment. Lung cancer will move, patients' performance status will deteriorate. And if you're wanting to give them chemotherapy and immunotherapy together, you want them to be fit.
Thank you. And I guess a reminder to the English registrants that NHS England have made dabrafenib trametinib combination available for BRAF V600 mutant patients. And so now it's very much beholden on us to ensure we've got BRAF genotypes coming through as well, Alastair. You do be in agreement with that?
Completely agree.
Alastair, one question that's come through is about PS2 patients. So these were excluded from this trial and have by and large been excluded from all trials. Do these patients benefit from checkpoint inhibitors?
So there's been a couple of nice studies that have come out recently, including one this week of patients with performance status 2 receiving first-line pembrolizumab in the high PD-L1 expression. And I guess those are the patients you'd like to avoid chemotherapy. Unfortunately, those results mostly have been disappointing. The Italian study, they pointed out that those patients who were performance status 2 due to comorbidities actually did quite well. It was the patients who were performance status due to tumor burden, presumably have high levels of cytokines, a very, you know, poor form of tumorigenic inflammation, that these patients do not do well with single agent immunotherapy. I think the issue about trying to give chemo immunotherapy to the performance status 2 is it's a difficult treatment to deliver. I would love to see the ability within the NHS to maybe give one cycle of chemotherapy to patients who are poor performance status due to disease burden, and if they pick up, to add in the immunotherapy. But I don't see that coming in anytime soon, unfortunately. We do not have that flexibility within the NHS.
Okay, thank you, Alastair. And in the interest of time, we'll close your presentation, and I'd like to thank you very much for your efforts. I'd like to welcome our second speaker for the evening. Our second speaker is Professor Fiona Blackhall. Professor Blackhall is a consultant medical oncologist at the Christie Hospital in Manchester and Professor of Medical Oncology at the University of Manchester. All of you online will know that Professor Blackhall is one of the first people that started treating ALK-positive patients in the UK and has been seminally influential in being a co-author in the profile trials in the early days of Crizotinib in ALK-positive disease. And therefore, I'm absolutely delighted, Fiona, to welcome you here to tell us about the EXALT-3 study. And apparently we have a new drug called Ensartinib. So over to you, Fiona.
Thank you very much, Sanjay. It's a real pleasure to be participating in this BTOG symposium and to be discussing this phase 3 study. Alastair just highlighted the importance of molecular profiling, and this study is strictly for patients with ALK-positive non-small cell lung cancer, a phase 3 randomized study of Ensartinib versus Crizotinib. Ensartinib is a second-generation ALK tyrosine kinase inhibitor, and Crizotinib, of course, is the first-in-class, first-generation ALK tyrosine kinase inhibitor. So this was a fairly straightforward study design, Ensartinib versus Crizotinib with a 1-to-1 randomization. Patients had ALK-positive non-small cell confirmed by central confirmation using FISH, but of course we usually go ahead with the results of immunohistochemistry in our everyday practice, and that is equally valid compared to confirmation with FISH. Patients with stage 3B and 4 disease, patients with performance status 2 were eligible alongside 0 and 1. No prior ALK inhibitor was permitted, and less than or equal to 1 prior chemotherapy regimen. Stratification factors, then prior chemotherapy performance status, geographical location, and most importantly for these drugs, presence or absence of brain metastases at baseline. There was no crossover allowed on study, and the trial was fully accrued as of November 2018. The primary endpoint was a blinded independent review committee assessed median progression-free survival by RECIST, and quite standard secondary endpoints of note overall response rate and then response rate intracranially. So these are the demographics and baseline characteristics, and as you can see, these characteristics are what we would expect for an ALK-positive population. The median age in the 50s, younger than our lung cancer population in general, but extending at the upper bound to octo and generians and 90 years old in the Crizotinib arm, so elderly patients included, about 20%, approaching 20% greater than 65 years. About half were male or female, and about half were Asian ethnic origin. The majority, over 90%, equal performance status 0 and 1, and then the majority never smokers. Current former smokers, about 40%. Many of these will most likely have stopped smoking some decades ago or been light former smokers. Very few patients had had prior radiotherapy to the brain, but about a third on each arm had brain metastases at baseline, and 24% and 29% respectively had prior chemotherapy. So this is the primary endpoint, progression-free survival. This is a positive study. The median progression-free survival, 25.8 months for Ensartinib, and for Crizotinib, 12.7 months, which is what we would expect for Crizotinib. Hazard ratio, 0.51, and highly statistically significant. So, are we surprised by this result? Well, we knew early on in the development of Crizotinib that there were characteristic patterns of progression and mechanisms of resistance, in particular isolated CNS progression, and then kinase domain mutations in the ALK tyrosine kinase domain. Another mechanism of progression is epithelial mesenchymal transition, which is also potentially targeted by Ensartinib. So our second generation ALK inhibitors were all developed to have better CNS penetrance, to be more potent inhibitors of ALK tyrosine kinase, and to be active against Crizotinib resistance mutations that emerge under treatment pressure on Crizotinib. So what we need to ask ourselves, and what our patients might ask us, is whether there is a best second generation ALK inhibitor. And here, in a very simplified summary, so that we can compare across trials, given the caveats of cross-trial comparison, but still compare broadly where these second-generation ALK inhibitors are at, you can see here that the response rates are broadly similar. The progression-free survival is similar for Alectinib, Brigatinib, and Ensartinib, at least 24 or 25 months. I have not included on this slide some updated analyses, more mature analyses that push the progression-free survival out further for Alectinib, but without showing you the curve, so you'll have to just imagine in your mind's eye, there is a relative flattening of the curve at the 24 to 30 months. And so this makes the exact assessment, the point estimate of the median survival, quite difficult. So Brigatinib mature data is still awaited, and Ensartinib more mature data is still awaited. But on the first announcement of these studies, the PFS is around this benchmark, and certainly superior to the 16 months for Ceritinib, with the ASCEND-4 trial, not against Crizotinib, but against chemotherapy. And the important thing in all of these second-generation ALK inhibitor studies is that Crizotinib has been very consistent in its performance of a PFS 9.8 to 12.7 months, response rate about the same as the second generations. Then let's look at the intracranial response rate. It was in most studies nearer 20%, than in one study 50%. And here for the second generations, intracranial response rate, 73%, 81%, 78% higher. And then for Ensartinib, 64%, so numerically lower. What do we think of that? Well, I would caution here, low numbers. We have 11 patients who had measurable brain metastases on Ensartinib, 19 on Crizotinib. And so I think it is difficult to truly suggest that Ensartinib might have lower intracranial activity. So let's move on now to side effects. And I have dropped Ceritinib off here. I have compared those second generation ALK inhibitors that have surpassed that 24 month PFS in the randomized trials. And can we tease them apart then on the basis of side effects and use that to select a best one for our patients? Broadly, serious treatment-related AEs are comparable across the different trials. Fewer dose reductions, potentially for Alectinib. Dose discontinuations, however, also similar. A point here about transaminases. In our everyday clinics, we see this often, and they are a class effect very common for all ALK TKIs. It is, however, often difficult to separate paper toxicities from clinically significant toxicities. And then I think it's quite interesting that despite the very similar efficacy and potency of these drugs, the side effect profiles do differ. There are distinctions between them. And what I want to do today is draw your attention to those for Ensartinib, our topic in hand, where rash, pruritus, and pyrexia were top reported AEs. Quite different from Alectinib and Brigatinib in that regard. Drilling down on that further, we can see here versus Crizotinib from Dr. Horn's phase 3 study, ALT increase, AST increase get first and third place, and then rash in 70% of patients. The majority in green here, grade 1, less grade 2, but about 10% grade 3. And we know for patients on these generally very well tolerated inhibitors and for a median exceeding 20 months, that rash, even at grade 1, is a nuisance and a problem. So, where are we at the moment in our treatment landscape for ALK-positive non-small cell lung cancer in the UK? This is our nice algorithm from April 2020. And again, it highlights the importance to subtype your patient to know the molecular subtype of their non-small cell lung cancer. For ALK-positive, we first had Crizotinib, it remains a first-line option, then Ceritinib, and then Alectinib. In the second-line setting on progression, we have Brigatinib and Ceritinib approved and funded following progression on Crizotinib, but not following progression for Alectinib or Ceritinib. So for the two second-generation first-line options currently, on progression, we move to chemotherapy-based regimens. Despite COVID taking all of our attention through May, Lorlatinib, a third-generation ALK inhibitor, was recommended by NICE for previously treated ALK-positive non-small cell lung cancer. Following Alectinib or Ceritinib, given as the first ALK tyrosine kinase inhibitor, so second line, or following Crizotinib as the first and at least one other ALK TKI, third line. Just before the World Lung Symposium last weekend, there was a press release for a randomized phase 3 study of Lorlatinib compared with Crizotinib, the so-called CROWN trial. It has met its primary progression-free survival endpoint. We have not yet seen any numbers for that study, but it is positive. And back in May, the US Food and Drug Administration approved Brigatinib for first-line treatment of ALK-positive non-small cell based on the trial data that I showed a few slides back. So the question that we need to really address for all of these inhibitors, whichever we use, is that eventually progression does occur. And there are a variety of mechanisms. I want to focus on some of the points from this very nice slide from Dr. Christine Lovely's discussion. It highlights a number of important points. This first is a patient who was treated with Crizotinib and who developed disease progression, was assessed for ALK tyrosine kinase mutations, and a 1152V mutation was present. Ensartinib was commenced. There was a RECIST response, and the level of the mutation in the blood disappeared. The mutation level then started to rise, and in fact, it was a new mutation. Continued radiographic response here, but then here, disease progression and the emergence of another ALK mutation, E1210K. So in this chart, this grid here, this is a list of ALK tyrosine kinase mutations that occur on exposure to an ALK inhibitor. And along the top here, it's a very small font, Crizotinib, Ceritinib, Ensartinib, Alectinib, Brigatinib, Lorlatinib. And where there is a red, there is resistance. Where there is green, there is sensitivity, and the amber somewhere in between. So if we look at the E1210K that developed in this patient on Ensartinib, we can see that we have red, amber, red, red, amber, green for Lorlatinib. So only Lorlatinib would be expected to have activity now in this patient. And when we look at the Lorlatinib column, then Lorlatinib has more greens than any and a light amber. And so this third generation ALK TKI might potentially be our best in class. We don't yet know. And I'm going to just highlight this anecdote. Always dangerous to guide our treatment algorithms according to anecdotes, but this remains a really fascinating case, published 4 years ago now by Riyaz Shah, who really led the field globally in the development of these agents. And this is a patient who received Crizotinib for about 18 months, then developed resistance and was given Ceritinib for a short time. Resistance was put on an early phase trial, then was put onto chemotherapy, then Crizotinib was tried again and it was not effective. And at that point, before receiving Lorlatinib, there was a very heavy disease burden in the liver. You can see the response here to Lorlatinib, a duration of response, then progression. A further biopsy at this time, and again, at a point where the patient had a heavy disease burden, revealed a resistance mutation, L1198F. And this mutation turns out to change the chemistry of the ALK tyrosine kinase domain again to resensitize it to Crizotinib. So the patient then got a meaningful clinical benefit from a re-challenge for a third time with Crizotinib, having developed this mutation. So I'm going to close now with this slide and my take-home message today, which is that Ensartinib from this trial is clearly another first-line option for ALK-positive non-small cell. I'm a little concerned about the rash, but even with the rash aside, it is clear from our second-generation inhibitors that we don't yet have a winner, a definite winner. And this is a patient of mine who was diagnosed shortly after participating in the Amsterdam Marathon some years ago. And for our patients, we need to continue to evolve our treatment algorithms to be sure that we can select the right ALK inhibitor at the right time. There are a lot of questions. I've got 3 here. First, has a plateau, let's say a median PFS of about 24 months, has that been reached for second generation ALK inhibitors? Will the results for the third generation drug Lorlatinib in the CROWN trial exceed this plateau? Will we need to do a head-to-head of Lorlatinib versus second generations? Is that the right approach for first line? Or do we need to get cleverer if we can, and can we use our current menu of ALK TKIs, recycle them for use in a highly individualized and precise way for each patient according to the ALK resistance mutation that the patient develops on treatment? There's a caveat there because not all patients develop an ALK resistance mutation. There are other mechanisms of resistance that are more complex potentially to tackle. So ongoing studies continue. Second line, Brigatinib is being compared head-to-head versus Alectinib. And then we have some complex studies that are looking to precisely match the ALK resistance mechanism with efficacy to an ALK inhibitor. And let's not forget too, tackling oligometastatic progression, our Cancer Research UK study that is up and running again post-COVID, the HALT trial of stereotactic radiotherapy for sites of oligometastatic progression. Thank you very much for your attention.
Thank you, Fiona. Great presentation. A couple of quick questions and then we'll close. One question that's come in is it ethical really not to have crossover these days with our trials? Again, we have another trial which doesn't allow crossover. We'll hear Crown, which won't allow crossover in the future. Is it ethical? It's
a really good question, and implicit in the question, I would challenge not allowing crossover. I didn't present the, at present, very immature overall survival data for this phase 3, but there is no significant difference for Crizotinib or Ensartinib at this point in time. We've seen that for the other second-generation studies against Crizotinib, and that is because patients are managing to get onto another therapy, most usually an ALK TKI. But until we have that piece tightly matched and integrated in a trial alongside resistance mutations, then we're going to struggle to really optimize our care paths for our patients.
And we have all these choices now. We'll have Ensartinib coming along. We'll have soon, hopefully, Brigatinib if that gets funding approval. Eventually, if Crown is positive, we might have frontline Lorlatinib. How are we going to choose?
So, I don't know. And what it might boil down to some extent, dare I say it, is not just clinical effectiveness, tolerability, but cost effectiveness of these agents. But what we lack in the UK compared to other countries is to be able to do some individualization and to do molecular profiling and select according to resistance, mutation, presence or absence, or the exact nature of it. So how we work collectively with the evidence base, with NICE, with our regulatory authorities, to get more flexibility and be able to choose for an individual patient, also according to how they tolerate our first line selection. If there is an intolerance, being able to switch to one of the others. We need that flexibility. That's the next step for us.
And I know that many of us are working behind the scenes to try and ensure that we have these options coming through. So with that, and in the interest of time, thank you very much, Fiona, for your excellent presentation. I'm now going to move on to our third presentation of the evening and welcome to the webinar my colleague, Dr. Riyaz Shah, who's a consultant medical oncologist at the Kent Cancer Centre. He's an expert in mesothelioma and has been treating mesothelioma for many years and has lots of experience with immune checkpoint inhibitors. So, Riyaz, you're going to tell us about the CheckMate 743 trial.
Well, thank you very much for the invitation to speak. Welcome, everyone. I hope you're all well. It gives me great pleasure to present the CheckMate 743 study. It's a very, very important study in mesothelioma. So I'm going to do a bit of background, then go through the trial and give you my thoughts. So I want to ask for your forgiveness initially. You know, a randomized control trial is a randomized control trial, and a well-done randomized control trial is a very important bit of comparative data. In this disease, we only have one registered treatment, cisplatin Pemetrexed first line, from a trial that recruited patients 20 years ago. And it's very important to remember that. And when you're discussing anything, you have to put things in context of the different trials in that area. And so I'm comparing trials that have been conducted over 2 decades. And over 2 decades, so much has changed in terms of radiology, histology, supportive medicines. And so everything I say, you need to caveat with that understanding that this data set in this disease stretches back a long time. So let's just go through the basics first. So cisplatin Pemetrexed is the treatment that we give on the back of this emphasis trial published in 2003. And as I say, patients were recruited into this trial in 1999 to 2001. Cisplatin versus cisplatin Pemetrexed. Very simple. And things to note about this trial, they're all good PS, non-surgical candidates with pleural mesothelioma. It's only cisplatin, no carboplatin. cycles were given until progression or maximum tolerability. So in the cis-PEM arm, median number of 6 cycles were given and up to 12 cycles in the range. So not something that we would do in standard practice right now. And if you look at the results of this trial, that's the overall survival curve. So the median survival went from 10 to 13.3 months. And I think now in the world of mesothelioma, in the world of immunotherapy, medians get a bit difficult, hazard ratios get a bit difficult. And one of the things I think does give a lot of insight into what's going on is landmarks. And I think we do need to look at landmarks a bit more, particularly when looking at immunotherapy trials. So if we just look, and this is not published, this is just me drawing lines on the curves from the paper, roughly I estimate that about 20% of patients in this trial were alive at 24 months. So that's the emphasis trial. There was another trial done around the same time, 2000 to 2003, comparing cisplatin to cisplatin Reltreksed, and it showed very similar results, a significant improvement in overall survival. The numbers, absolute numbers, were a little bit less than the emphasis trial, but the landmarks are fairly similar. Now, this drug was never licensed, never approved, and it's something most of us have completely forgotten about. Really an interesting lesson on what can happen when you don't have a big pharma company backing your drug. Now, there's one other very important trial that we need to understand what's going on, and that's the MAPS trial. So this is a French academic study comparing chemotherapy with cisplatin Pemetrexed for up to 6 cycles, compared to chemotherapy with cisplatin Pemetrexed plus bevacizumab. Bevacizumab given for up to 6 cycles with the chemo and then continued as maintenance until progression or tolerability. This was done about a decade ago. So 10 years later, we do this trial, patients randomized from 2008 to 2014. And if you look at the results from the published trial, it's significant, favoring the addition of bevacizumab by a relatively modest amount. The median goes from 16 to 18.8 months. Updated data from this trial was presented at World Lung in 2019. And if again you look at the landmarks, what you see is the doublet of cisplatin Pemetrexed delivers 63% 12-month and 30% 24-month survival, which is really interesting because that's 10% more people alive at 24 months with exactly the same treatment 10 years later. So that's sort of stage migration and changes in treatment. Now, let's get on to CheckMate 743. So talking about CheckMate 743 here, so this is a randomized trial, unresectable pleural mesothelioma, no prior systemic therapy, fit patients with a good performance status. We've got 605 patients randomized 1-to-1 to receive either conventional standard treatment, cisplatin or carboplatin here, for up to 6 cycles, and the investigational arm was immunotherapy. But immunotherapy with a slight difference to what we're generally used to in thoracic oncology. This is double immunotherapy. This is an anti-PD-1, Nivolumab, with an anti-CTLA-4, Ipilimumab. Ipilimumab is given every 6 weeks, Nivo every 2 weeks, and patients can continue this until progression or maximum tolerability for up to 2 years. The primary endpoint was overall survival. Look at the baseline demographics of the patients in this trial. You will see that they're well balanced. You will see that about 40% of patients have a PS of 0, 40% of patients were never smokers, 2/3 of patients were epithelioid, 3/4 of patients were epithelioid, and 1/4 of patients were non-epithelioid. And if you look at PD-L1 expression, about 20 to 25% of patients had no PD-L1 expression, and 80-odd% of patients had PD-L1 expression. Slightly different from what we see in lung cancer, where probably 40 to 50% of patients that we see with non-small cell lung cancer have less than 1% PD-L1. So this is the big slide, the money shot slide. This is the overall survival in the entire group of 600 patients. And what you can see here is that there is a significant benefit for the combination immunotherapy arm over chemotherapy. If you look at the landmark at 24 months, 41% of people alive versus 27. The median's gone from 14 to 18 months. The hazard ratio is 0.74. The confidence interval is below 1. Everything adds up to a positive trial. So this is excellent news. If you look at the subgroups within this trial, patients what you see is a general trend favoring immunotherapy over chemotherapy pretty much across all the parameters. The two that I think we do need to focus on specifically are histology. You see a massive benefit in the point estimate for non-epithelioid tumors. For epithelioid tumors, the point estimate is still favoring immunotherapy, but the confidence interval crosses 1, so it's not statistically significant. And if you look at PD-L1 expression, certainly the presence of expression favors immunotherapy. The absence of PD-L1 expression, I mean, it's very close to 1 there, but it is just to the left, just suggesting that in PD-L1 negative patients, there may be a slight benefit to the immunotherapy, although those confidence intervals are big. It's only 20% of the patients, so the confidence interval spread is quite wide there. Now, look at those subgroups in terms of the curves is quite interesting, because if you look at epithelioid patients, you can see that, look at the 24-month landmark, 42% of patients alive. Epithelioid, 38% of patients alive. Non-epithelioid, there doesn't seem to be much difference in the curves for the patients given immunotherapy, but chemotherapy, you see a big difference. You see that chemotherapy in non-epithelioid is performing, well, frankly, abysmally compared to immunotherapy, whereas in the epithelioid group, there is a numerical difference, 16.5 to 18.7. You can see that the immunotherapy treatment arm is tracking above. So there is a difference, but it's not statistically significant. And if you look at PD-L1 expression, similarly, the presence of PD-L1 expression, you see this difference that is robustly different, 13.3 to 18 months, positive hazard ratio, confidence interval less than 1. The 24-month landmark, 28 up to 41%, so clear difference there. Much, much less obvious in the PD-L1 negative group, where, you know, there isn't much difference between these curves. But again, you know, there is a sort of point estimate at 24 months, slightly favoring immunotherapy. And you see this slight crossover of the curves, which I'll reflect on a bit later, but that is not statistically significant. So let's just look at these. So we started with a trial emphasis 20 years ago that delivered 20% people alive at 24 months with chemo, median survival of 13.3, exactly the same treatment 10 years later in the MAPS. We get 30% alive at 24 months and the median is 16.1 months. And then we move to this study here, CheckMate 743. All of these figures are for the chemo arm, and you see that 27% of patients are alive at 24 months, 14% median survival. And you see this detriment in the non-epithelioid, but pretty much similar figures for all the other subgroups. You do note this difference, PD-L1 negative, PD-L1 positive for chemo, 13.3, 16.5 months, does slightly imply that there may be some sort of prognostic issue with PD-L1 in this disease. That's just hypothesis generating. Look, oh, can I go back a slide, please? I don't know how to do that. Look at immunotherapy. You see a very consistent signal. We're seeing consistently, regardless of histology, regardless of PD-L1, the numbers are consistently in the high 60s or 70%, 24-month survival around 40% consistently, median survival 18 almost consistently. It's very impressive, very uniform data that we're seeing. So what are the conclusions of the authors? It met its primary endpoint. There was a survival benefit for Ipi versus chemo, regardless of histology. The PD-L1 data was descriptive. They don't want to make any firm conclusions from that. I haven't shown you the safety data because time is of the essence, and essentially the safety data shows no new signals in terms of toxicity differences between, you know, for immunotherapy and chemo. We've been using these treatments. We know what the toxicities are. And so their conclusion is this should be considered as a new standard of care. What do I think? I think that, well, I agree with those conclusions. I think that if reimbursed Nivo-Ipi is the first-line standard of care, we're reimbursed, particularly in the non-epithelioid tumours. I don't think PD-L1 is discriminatory enough to select therapy to say to a PD-L1 negative patient, you shouldn't have immunotherapy. But the key thing, if you go back to that slide, is if you look at the MAPS data, you'll see that that matches CheckMate 743 very closely in terms of the 24-month landmark and the overall survival. So this is a trial versus chemo, not chemo plus bevacizumab. Now, it's important to know that chemotherapy plus bevacizumab is not a licensed indication, but it is a standard of care in certain health economies, and for them, that may be an issue. The only other thing I want to point out in small print here is the PFS curve. This, I haven't shown it or dwelled on it, but it does show quite a significant crossover, similar to what we've seen with some other Nivolumab trials that were presented early on in the lung cancer field, which implies that there's a subgroup, that there's a biological subgroup in whom the immunotherapy perhaps isn't working so well, and another subgroup in whom it's working very well. And the question is, can we pick those people out? So that's all I'm going to say. Thank you very much.
Riyaz, thank you very much for that excellent presentation. So we have a positive trial in mesothelioma, the first randomized phase 3 positive trial that I can recall in my professional lifetime. So is this a new standard of care for mesothelioma, Riyaz?
Well, the standard of care in my clinic tomorrow or this next week is the same as ever. Nothing's changed to date. This is a company-sponsored registration trial, and I have no doubt that this will result in Nivo-Ipi getting a first-line license in this setting. I mean, if somebody walked into my clinic today and I could do anything I wanted, I think, yes, it would be a very reasonable option.
One of the questions that has come in is, well, you know, you've pointed out that actually the landmark was pretty similar to cis-Pem-Bev from MAP. So why should we bother with Nivo-Ipi?
Well, cis-Pem-Bev isn't approved. I mean, the only people getting cis-Pem-Bev in this country with mesothelioma either getting it subsequent to first line and they're paying for it, basically. They're paying for it either through a legal claim or private insurance or their own pocket. You know, it is not a reimbursed treatment, and it won't be a reimbursed treatment because it's not licensed. And it's not going to be licensed because it is an off-patent drug, and there's no interest in pharma to go and try and get a label for that drug in that indication. So that is, I think, where Nivo-Ipi is going to slot in, because once this is registered, then it becomes a on-label treatment. Because it's an on-label treatment, you can go to NICE, you can start a negotiation on price, and if BMS can get that deal done with NICE, this becomes a treatment on our option list.
And then if it is on your option list, we've seen a massive benefit with the sarcomatoid, not so much a clear difference with the epithelioid. Where do you, I mean, should we be using it in our epithelioid patients?
So the way I would think about this is there's the science and then there's the practicalities of treating people and giving patients the best treatment and the best options. If Nivo-Ipi was approved in my practice tomorrow, let's hypothesize that that happens, then it would become my standard of care, because the data for subsequent line immunotherapy is not that good. You know, it's much more higher response rate than chemo, but if you look at the PROMISE trial, there isn't a survival benefit to pembrolizumab versus chemotherapy. So, and we have no reimbursed options for immunotherapy. So if Nivo-Ipi becomes approved and NICE approved, then suddenly this is the only pathway to immunotherapy for mesothelioma patients. And I think, you know, mesothelioma patients are a distinct subgroup to our normal practice. Many of them haven't smoked very much. They often quite a good number. There are lots of frail ones, but a lot of patients are relatively young, relatively fit, and really up for everything. So this will become the only immunotherapy option for them that's reimbursed on the NHS. I would have thought that regardless of PD-L1, regardless of histology, you would use your Nivo-Ipi first and then look at other options subsequently. So chemotherapy becomes a second-line treatment.
So in 743, there was a signal of efficacy with the PD-L1 positive population, understanding this as an exploratory analysis. Do we now need to do PD-L1 testing in all our mesos? So,
you know, it's of academic interest, I accept that, but in clinical practice, if you look at non-small cell lung cancer, if you look at the keynote trials, the licensed labels are in specific PD-L1 categories. Our reimbursed pathways for CDF say that, you know, you can give Pembro to someone who's 1 to 49 or greater than 50. So there is a licensing and reimbursement driven, forget the science, but there's a licensing and reimbursement driven compulsion to do the test, because the test and its result will directly reflect treatment changes. I think it's different here, and it really depends what NICE guidance says. But if I'm quite sure this will get a label, an EMA label across all subgroups. I'll be very surprised if it's only in non-epithelial or only in PD-L1 positive patients. Assuming that happens, and assuming NICE negotiations are done on that basis, and the drug company could say, we'll just pick the 80% who are PD-L1 positive for NICE. There's nothing to stop them doing that, because all sorts of, you know, negotiations happen behind closed doors. But it all depends what the NICE guidance. If the NICE guidance says, or CDF guidance says it's got to be PD-L1, we've got to test them. Outside of that, I wouldn't bother, because a PD-L1 negative patient coming into my clinic, I couldn't genuinely say to them, you know, this is not going to work in you. It's not like an EGFR test. And
we know that it's heterogeneous expression in mesothelioma. And we know
it's heterogeneous, absolutely. And you know, the other thing is toxicity. I've used Nivo-Ipi quite a bit in trials and.
Can I pause you there, Riyaz? I'm going to ask you a question that's come in about whether we can extrapolate this to peritoneal meso.
Well, who knows? I mean, let's do trials in peritoneal meso, but it's never going to happen. They're so rare that there have been almost no, you know, definitive chemo studies in peritoneal meso.
But if the approval was from NICE to any form of mesothelioma, not just pleural, would you be comfortable with that? We give cis-pem to our peritoneal mesotheliomas without any trial data.
Yeah, I mean, I think it's all about fitness. We have to extrapolate. The only way to treat, there are no, if you just go by labels and you believe in labels, then you know, small cell lung cancer of the lung and small cell lung cancer of the liver, or small cell lung cancer of the rectum, generally treated in the same way. You know, the only option for those patients is palliative care then, which I think, you know, there are a subset of mesothelioma peritoneal patients that I have met who are actually quite fit and perfectly capable of withstanding systemic treatment and immunotherapy. So yeah, I think it would be harsh to restrict it only to pleural. I think it would be very unfair. It's a very small group of patients who have very few other options.
Okay, thank you very much. So it brings us to the hour, and I'd like to thank you, Riyaz, for that presentation. And importantly, I'd like to thank all our presenters for taking time out from their diary, getting the slides through very quickly since presentation on Saturday, and putting together this discussion. I wish we had more time to discuss things. If you, as an audience, want to hear more from experts discussing stuff, please be in touch with us at BTOG, and we can organise webinars if that's of interest to you as a community. Otherwise, I'd very much like to welcome you to the next BTOG webinar, which will be all about ESMO. ESMO 2020 in an hour, another live event being held on Tuesday, the 22nd of September at 17:30. Mark it in your diary. Believe me, there's going to be lots to discuss. And with that, I'd like to thank you very much for your attention and look forward to seeing you again at the next BTOG webinar. Goodbye.